Good afternoon. My name is Marie Owen, and I'm a member of the Health Quality Council of Alberta Board of Directors. I will be the moderator for this webcast this afternoon. And for those of you who are on Twitter, our hashtag for today is hashtag PXAward17. Welcome and thank you for joining us today for the webcast to celebrate the second annual Health Quality Council of Alberta Patient Experience Awards program. For those of you who don't know the Health Quality Council of Alberta, it's also known as HQCA. It's a provincial agency that pursues opportunities to improve patient safety and health services quality for Albertans. It gathers and analyzes information and collaborates with patients, Alberta Health Services, healthcare professionals, academia, and other stakeholders to drive actionable improvements to health service quality and patient safety within the healthcare system in this province. This awards program is also sponsored by the HQCA and the HQCA's Patient Family Safety Advisory Panel. Now, for many years I worked as a nurse during my career, and I was really pleased to see that we're now putting a stronger emphasis on the patient experience, and I'm delighted to be part of this work and part of these presentations today. Now, being on the board of the HQCA, I'm really thrilled that we are recognizing and celebrating the wonderful work that's being done by healthcare providers and teams that's really going to improve the experience of patients and families in this province. And of course, when we say patients, we also are including anyone who's receiving healthcare services, including clients, residents, and of course their families. First of all, I want to say how incredibly impressed I was with the work that's going on in this province. Thank you to everyone who submitted an application. We had 27 applications submitted from across the province and from a variety of work care settings that demonstrate the amazing work that takes place every day to make a positive impact on patients' experience in this province. The submissions that were selected to receive the 2017 awards showed a dedication to promoting a positive patient experience, and they demonstrated that their work is truly making a difference, and you're going to hear more about that when you hear their presentations. And for their efforts, each team here will receive funding of $2,500 for an educational activity within their organization. I now look forward to listening to the 4 recipients of the 2017 Patient Experience Awards and to learning more about what they're doing to improve the patient and family experience. But before we get into the presentations, I'm really pleased to invite opening remarks from Dr. Greg Powell. Greg is a patient and family representative from HQCA's Patient Family Safety Advisory Panel. Greg?
Thank you, Marie, and good afternoon to all. I, as you know, I'm introduced as a physician, and I have had lots of experience from that side of the healthcare provider world. Today, I'd like to talk about being a patient. I've had the opportunity to be a patient more times than I would like to tell you about in the last few years, which has given me a perspective I didn't have before. Of necessity, our healthcare system is huge. It's like a giant ocean liner, and to turn it takes some time. And of course, with medical advances and all the other things going on in our society, it's tremendously difficult for a large system across our country to keep up with the times. So it is inspiring and wonderful that individuals, related groups, and people within our larger system take the time and are inspired to make differences to the patient experience. There are lots of gaps that occur regularly in our ability to communicate and deliver healthcare services at the level of excellence to which we all aspire. And I sat as a judge on the panel, and as Marie said, it's been a wonderful experience to be able to review all those things and to see that there are these individuals and groups within our healthcare system that are taking the initiative to provide patient care in small pockets that makes a true difference to the patient's experience. So I look forward and I offer congratulations to your participation and your inspiration. So thank you to all, and back to Marie.
Thanks, Craig. We're now going to move into the 4 presentations from the teams that were selected for these to receive an award this year. After the completion of the final presentation, there will be a 10-minute question and answer period. And we would ask you that you submit your questions along with the name of the presenter that you would like to address your question, and write that in the chat area on your webcast screen. It is now my pleasure to introduce Cheryl Cameron, who is the lead for the EMS Palliative and End-of-Life Care initiative entitled Assess, Treat, and Refer. Cheryl?
Well, good morning, and thank you very much for giving us the opportunity to come and talk a little bit about our initiative. And it's definitely an honor to be here representing a program that we've been developing and expanding across the province for the last couple of years, and really has had thousands of people involved in impacting the patient experience. So the name of this initiative is the EMS Palliative and End-of-Life Care Assess, Treat, and Refer program. And it is a provincial initiative where EMS is working collaboratively with our other partners in primary health and continuing care to support palliative and end-of-life care patients in the home setting. So the problem, we do know that most Canadians prefer to actually be at home in their home setting when receiving palliative and end-of-life care. And yet we know that many Canadians actually do end up in hospital due to symptom crisis. And there's a mismatch there then between patients' preference of location of care and what we're able to kind of currently provide. So sometimes complex care issues leave our community clinicians and our paramedics with no option but to transport patients to hospital if they do have increase in symptoms. So things like pain, shortness of breath, nausea, vomiting. And we know that the emergency department is not a very pleasant experience for these patients specifically, although they are very ill. When you're looking at prioritizing patients in the emergency department, they might not be as high preference as other patients that are in the emergency department. And that setting doesn't really allow for the kind of comfort that home does. So we kind of wanted to see what we could do differently there. There was actually a recommendation from the Health Quality of Council of Alberta back in 2012 to look at supporting these patients and what we could do better to manage unexpected symptom crisis in the home setting rather than have them be transported to hospital. So a collaborative initiative between emergency medical services and then, as I mentioned, other members of palliative teams and primary care came together to build this initiative. And we're looking right now at adult patients who are receiving palliative and end-of-life care in the community who would like to remain at home. So the Assess, Treat, and Refer program is really a way for our paramedics and other members of the patient's primary care team in the community to work together to manage that symptom crisis. So supporting symptom management in the home rather than having the patient transported. And for EMS, that was quite a difference in how we normally do work. We tend to come into the home and identify what's going on with the patient, manage their symptoms, and then take them to ED. And so it was quite a difference for us to be supporting those patients in place and being supported to be able to give pretty significant symptom management medications in the home setting and leave them there at home. Any clinician or other regulated healthcare professional that's involved with the patient can be involved collaborating with paramedics to be able to keep that patient at home. So that might be home care, or it could be a primary physician, it could be their palliative physician. Kind of depends on where they are in the province and who's actually managing their care. So there's no limitations there. It does use our current EMS resources, so our ambulances that are out in the community already are the ones that are providing this different method of care, and it uses our current EMS formulary. So it's not a separate team of paramedics, it is our frontline 911 paramedics, and no additional medications or equipment was added to the ambulances. So really looking at what did we have out there in the community and how can we use it in a different way in collaboration with other members of the patient's care team. There's a mechanism for EMS to respond non-lights and sirens, which we know is actually preferred by this patient population. The last thing that this population really wants is a lot of hoopla, lights and sirens response, potentially other medical first responders coming to their homes. So there was some emphasis on trying to develop a pathway where paramedics could respond non-lights and sirens to these calls. It's been rolled out provincially in both rural and urban settings across the province. And it's really based on a consult model with an online physician to build a tailored symptom management plan for that client. So that's new for us in EMS as well. We tend to do a lot of our work with standing protocols, but for this patient population, we want to make sure that the care we're going to provide in that symptom crisis is in line with the rest of their care plan. So being able to talk to their most responsible physician or their palliative physician that's following them to be able to build that tailored care plan and support our paramedics in doing some things that are a little bit different and out of the norm for them. And then follow-up care coordinated by their clinician, who might be a member of home care or their physician, depending on how they're being followed in the province. So we actually have rolled this program out since April of 2015 across the province. And so in our first year, we did find that most of our patients were successfully treated in-home, if that was their preference, and not transported to ED. We know when talking to family members that the majority of the family members did say that the patient received treatment in their preferred location of care. And we did quite a bit of engagement with patient and families and also staff around their satisfaction with the program. And we found there was high satisfaction with staff and family around enhanced collaboration and communication between paramedics and other community palliative care providers. So what do our families say? I've been really privileged to be able to see a lot of survey data back from our families. We've been doing a lot of phone conversations with family members after they've had an event with paramedics and are the community partners keeping patients at home. And one of the most salient quotes that we have from one of our family members, I'll just read it for everybody, is he said, "I still remember when they came through the door, the amount of compassion. They seemed so completely understanding about where I was. It made the difference between him dying in hospital and dying at home. You'll get, as I did, an amazing sense of comfort to know they are really fighting for you, to make your wish come true, to keep you at home." And that's from one of our family members, Richard Horth. So in regards to spread, this program really has already spread and scaled across the province. Before 2014, there was some experience in our Calgary metro area and also Edmonton zone where paramedics were working with palliative care teams and home care to treat patients in place. And that program was leveraged and scaled across the province in the last 2 years. In addition, we've opened up access for the program to patients and families. Initially, it was the home care clinicians in the home that were calling EMS when they had a patient in symptom crisis to support that patient. And now EMS is also able to identify patients who call themselves into 911. Once they get to the scene, they're able to identify if those patients would be appropriate for treat in place and connect back with their primary care providers to make that happen. So that expansion happened in October, and we've seen a significant number of events, especially in our rural areas across the province since that happened. And this year, we're going to look forward into expanding out into pediatric populations as well. The other spread that's kind of happened is concurrently we have colleagues in Nova Scotia and Prince Edward Island that have implemented a similar program. So we've been very lucky to talk to them and see how their program's been going, and they've been finding similar findings and having similar experiences with patients and families. And we're currently working on a partnership with the Canadian Foundation for Healthcare Improvement and with our colleagues in Nova Scotia and PEI to conduct some return on investment evaluation to be able to see what this program is doing and if there actually is some cost savings in keeping patients at home as well. One of the things we're really excited to say that we've had in development of this program throughout is really important involvement of a patient and family advisor on our innovation steering committee. And so as this program continues to be developed and implemented across the province, we really lean on our patient and family advisors to let us know and make sure that we're doing what's in line with best practice with the patient experience. So that's all that I've got.
Thank you very much, Cheryl. We all know that patients don't journey through the healthcare system on their own, and when you have a testimony like you did from that, from the family member, that's pretty powerful evidence of the value of this program, so congratulations, well done. It is now my pleasure to introduce to you Heather Druin, Project Coordinator, Senior Centre Without Walls, Edmonton Southside Primary Care Network for the Edmonton Senior Centre Without Walls initiative.
Wonderful. Thank you so much. It's really an honor to be here, especially as our program is a relatively young program, and to be here and to be awarded this really shows that we're on the right track, and we'd love to share our findings with you and where we intend on going next. So, what is a senior center without walls? The name itself is not that intuitive, but what we do is we use conference call technology to bring together groups of seniors on group chats from the comfort of their own homes. We run programming on a variety of topics, such as you might find in a traditional senior center. But really, who we're targeting is those that could not access this programming. Mostly individuals who are homebound through a number of reasons. Could be transportation, financial, health, or mobility issues. And when we say older adults, we really mean the widest possible definition. And we understand there are some challenges associated with that. The diversity of a seniors population ranging from 55 to 105 is not lost on us, especially when it comes down to programming choices. But really, we wanted to include younger seniors who might be experiencing some of these same barriers to participating in programming on health and wellness, as well as social and recreational. The intent of our program is to reduce social isolations and increase the connections between our participants and the patients we work with. Currently, we're working with Edmonton area seniors, mainly brought to us through referral partnerships within our PCN, the Primary Care Network's clinical staffs, as well as with community partners in both the social and health and wellness sectors. Where this all began was through the identification of a high rate of social isolation and loneliness in our older adult population being served by the clinical staff at the Southside Primary Care Network. Our clinical staff was very aware of the health implications of an older adult who is isolated, and were able to identify these patients through a number of indicators. They might appear at appointments using them as social support, the clinical staff. They might even be able to identify their loneliness themselves. They may be becoming more withdrawn, or it could be led on to by a life change, such as a move or the death of a spouse. And while our clinical staff could do a great job of identifying them, the next step really wasn't that obvious for them, especially if this individual could not access, say, a senior center in the community or another traditional route of help. Really, they were limited in what they could do, both in their role and their time constraints for the visits and the importance of seeing the rest of the patients. They were at a stopping point, and when we delved into this issue further, we realized how personal the experience of isolation and loneliness was, and how coming up with a solution or one resource to help this was not going to work. What we wanted to do was build choice into our resources, as well as choice in how the clinician could go about helping this individual. When I got brought on board to start this program, we had an idea of what we wanted to do, but we had a blank slate of opportunity. And this was a really great chance for us to not only build our programming around the needs of our patients, but to involve the patients themselves in the building of the program and the procedures therein. We did this through several ways. We wanted to make sure our programming was very relevant to them, and that was done through intensive intake with all of our patients we interact with, allowing us to not only figure out what their likes are and their needs, but also flagging certain indicators for us where we could refer them to additional resources and help connect them to things that are already ongoing in the community. In addition to this, we're able to run our programming on 4-month cycles, which means that we have a very quick turnaround when it comes to improvements. We're able to take the feedback that we collect through both formal and informal mechanisms, formal being our advisory committee, which is made up of seniors in the community, as well as patients and participants and providers, and informal being the conversations we have during programming, challenges that arise while you're running these. I can't tell you how many times a conference call has gone wrong, and we're not immune to those problems either. But what we're doing is adapting as we grow and making this as accessible and relevant to our client population as possible. We also are able to do feedback interviews with not only our patients that we work with, but our healthcare provider presenters who are starting to develop these relationships with our clients. So what was the impact? What we really began to see was this relationship form, and we were able to spend more time with these patients and work very closely with them. We started hearing back from them that if they had a problem or a question or a concern, or even just needed to know the number or how to get a hold of a resource, they knew they could call us at any time, and we would try and help them to the best of our abilities. Whether this be a referral, an update, or even just a compassionate ear to hear about something that's going on in their lives. What we wanted to do was form tangible outcomes for their engagement. Really, the most frustrating thing for me is when you give your time and your expertise to help provide feedback into something and you don't know what became of that or what was done with it. And we really wanted to avoid that. We wanted accountability to our patients, and we wanted to show them that we were listening and that what they were saying was helpful and that we could work with it. This has really done wonders because it means that we are actually having patients come up with brand new ideas for programming or want to become more engaged with the process as we go. Another big finding was the increased accessibility of programming that may have already been available at our primary care network or in the community, but wasn't available to those patients themselves. We got rid of transportation barriers, the mobility issues, as well as something we didn't think of initially, but turned out to be a wonderful thing, vision issues. People were able to participate in these programs on equal footing, even though they might be experiencing these barriers in their lives. It didn't show over the phone. Ultimately, though, what we really wanted to do for an impact was reduce social isolation and loneliness and increase those feelings of community. And while we were getting a lot of feedback around the convenience of participating and the building of these relationships, really for some of our participants, this might be the only contact they have in a week's time. And I'll just read one quote here that really stuck at home for me. Everyone has to have a purpose in life, and without anyone to talk to, it's hard to have a purpose in life. And you become an island, and islands fall apart. So by creating this opportunity, we have a wonderful chance to not only help individuals, but build communities and allow them to help each other. What's next for us? We're very excited. As we've built this cyclical nature into our program, we can be a very responsive and dynamic program. We can change with our patient population as they come through our program, and we can grow as opportunities arise for us. We really have begun seeing this, but we are wanting to foster it moving forward. The idea of our participants taking on more leadership roles within our programming. I got a call the other day about someone who really wants to share their expertise from their previous job moving into a program. And what we want to do is support them, as well as recognize their talents and their experiences and facilitate that ownership of the program and the self-efficacy associated with that. And additionally, we would love to expand outside of Edmonton. We really see the benefit of this program for rural seniors who may not have the same amount of resources or may experience greater geographical barriers to becoming connected with communities and neighbors. I'd like to end off on thanking my participants and the patients that I work with. I tell them after every session, without them, we don't have a program. We have me talking on the phone. They're the bread and butter of what we do. They're the ones that bring their experiences and their joy to our program, and we're just there to facilitate these connections and get them what they need. Thank you so much, and I will pass it back to Marie.
Thanks very much, Heather. We all need social connections in our lives, and to provide an opportunity like this for seniors who cannot get out is such a good way to enhance the quality of their lives. I saw that on Global News, and I was very impressed, so well done. I now want to introduce Dr. Jennifer Toole-Friedman, a physician lead for quality and safety at the Alberta Children's Hospital for the Commitment to Comfort. improving the pain experience of children in Alberta's emergency departments. Jennifer?
Thank you, Marie. We're really honored to be able to share our work with you today. So I'd like to talk about the commitment to comfort and why it's so important to us. So we know that the treatment of pain is one of the most important priorities of patients and families that visit our emergency departments. And we're starting to learn more and more about the harm that comes when children experience untreated pain in the healthcare setting, both in terms of the immediate suffering, but also in terms of the long-term harms, which we often don't think about. And those can include post-traumatic stress reactions and also avoidance of future health care. So this really is an important issue that goes well beyond the immediate experience. And unfortunately, when children come to the emergency department, they are often coming in pain, and they may require procedures that could be potentially painful. In fact, just 14% of visits to the emergency departments in Calgary are for children with limb injuries, such as arm and leg fractures. And almost a quarter of children need needle procedures when they come to an emergency department. And so we really wanted to look at how well we were treating pain in the emergency department. And by saying we started in the Alberta Children's Hospital because that's where I work. And in talking to our staff, this was clearly an area that meant a lot to us, where we wanted to be doing a good job. And so we just started looking at, first of all, our healthcare records. And right from the beginning, we saw that only about a third of children who had an arm or leg injury were getting a pain medication, and on average it was taking over 30 minutes to deliver that medicine to them. And in fact, at the other emergency departments in the city, the wait was often more than 1 hour. And so we really felt that we could be doing better, but yet we felt that that was just part of the story, because we hadn't yet spoken to patients and families about what they were experiencing. So we started interviewing the patients and families that came to visit us with injuries. And they actually told us that much of the time they were satisfied and they felt that they were receiving good care, but 18% of our families told us that they were dissatisfied with the pain care that they received. And also another 18% of families said that they would have really liked treatment for pain, but no one offered them pain medicine. So this showed us some areas where we really knew that we needed to improve. And so we then embarked on conversations with our own staff and with additional patients and families, and also the Child and Youth Advisory Committee at the Children's Hospital. And we developed what we call the commitment to comfort. And what this says is that we'll do our best to promote comfort by helping to lessen pain and distress. And we want patients and families to partner with us and let us know how we can help. And so I'd like to show some of the resources that we've developed. And so you'll see on the left of the slide that I'm sharing one of the posters that's in every treatment space in the Alberta Children's Hospital, and now throughout much of the city of Calgary and the province in our emergency departments. But this is a poster that we place where patients and families can see. And in addition to having pain scales on it to help children describe their pain and to help staff measure the pain, we put a few things that actually kids told us that they wanted. So what you see is a comfort menu. And we had actually, in our conversations with our patients, sometimes we realized that they didn't know that they could even ask for an ice pack, for example, for an injury. Or perhaps they needed a needle and they didn't know that numbing cream was available. And as much as our staff try to offer occasionally, we might be thinking about other priorities and might not have offered. And so kids said, let us know that this is available, and then we can ask for it. And so we put a comfort menu on our posters, and this is now in our triage area and in every treatment space in the Alberta Children's Emergency Department and in the other emergency departments that have now joined us. In the middle of the slide, you see a poster. Again, this is positioned where patients and families will see it, and this is specifically about needles because, you know, we started out looking at fracture pain because that's such a common condition in emergency departments. And what really struck us is that a child could have a very angulated fracture that looked just awful, but all that the child cared about was whether or not they would be getting a needle. So as much as we wanted to continue to work on fracture pain, we realized that kids wanted us to work on needle pain. So we developed this poster that lets everyone know that we have numbing cream that can be applied before needles, and invites families to let us know that if we haven't yet offered it, that they should request it. Also on this slide, you see an example of what we call our comfort kits. And we know that when children are going to undergo a procedure or experiencing pain, distraction is actually one of the most powerful analgesics that we can use. And so this kit shows a bunch of distraction items that we have available for children that are visiting the emergency department and might need a procedure. And we also are showing a picture of a little individualized pain scale bookmark that can be given to kids, and they can use this bookmark to describe their pain, and it also is a little bit of a visual cue for our staff when they're holding that bookmark to remember to continue to check in with them frequently about what they're experiencing. And so I'd like to share a little bit of the impact of our work. So we started this work about 3 years ago. In the fall of 2014 was when we were planning it. And we started with the Alberta Children's Hospital with the idea that if we could make an impact there, we would then reach out and invite other emergency departments to join us. And so we're very happy to learn that that our work did make an impact. And in particular, when we talked to families about how they felt that their pain had been treated, the number that was dissatisfied with their pain care was decreased to 5%. And it was both at Alberta Children's Hospital and also at South Health Campus, where altogether we ended up speaking with over 1,000 families about their pain experience in the emergency department. In looking at the slide that I'm sharing, we have targets on the slide, and what I wanted to mention is that we chose those targets again based on what patients and families told us. So we started out asking, well, what's the right number for pain medicine? Because clearly treating pain isn't all about giving medicine, and the goal isn't for us to say, here, take some medicine. The goal is for patients and families to tell us what's right for them. Sometimes distraction is what's right for them. Sometimes a parent has already given some pain medicine before arrival and they don't need any more. So we needed to talk to patients and families to tell us what the target should be. And what we found was that around 40% of children that had a limb injury wanted us to give them pain medication. And similarly with time to getting pain medicine, we started out with a median of around 37 minutes, and that we knew that needed to get better, but how much better? And when we talked to patients and families, what we were most consistently told was, if my child is coming in pain, we really feel like we should be able to get medicine within 15 minutes or less. And so what you're seeing on this slide is that when we started the work at Alberta Children's and then spread to the other 3 hospitals in Calgary that see children, South Health Campus, Peter Lougheed, and Rocky View, you can see that we increased the proportion who were getting pain medicine to above our target, now 41%, and the time that it takes the typical child to receive pain medication in a Calgary emergency department is now down to 12 minutes. I'm really excited to share that we have now spread our work to almost 50 emergency departments in Alberta. And what this slide is showing is all of the emergency departments and in all of the zones in Alberta that are now working with us. And we're partnering with the strategic clinical networks, and we've invited sites to form their own quality improvement collaboratives, and we're hosting webinars where the sites that have joined us are learning about some of the priorities in caring for pain in children and what they can do, and specifically focusing on the things that patients and families have told us that mean the most to them. So including slides on comfort positions, which is another thing that we've learned is it's very, very distressing for families when children are restrained by adults that they don't know. And so we have a whole poster positioned for families to see about how a child can be held by a caregiver during a procedure so that they don't have to experience restraint. And all of these resources, including the comfort kits, distraction items, are being shared with all of our partners across the province. And really what we hope by doing this is that we'll reach as many children as possible, and that the more families can learn about how they can support the child, the more they can work with us to be active partners in improving the experience of children visiting the emergency department. Thank you very much.
Thank you very much, Jennifer. thing about kids coming in to emerge, they're usually accompanied by one, if not two, pretty upset parents. So if you can improve the experience for the child, you're no doubt going to improve the experience for the parents. So well done. And I loved your spread. Looks great. It is now my pleasure to introduce our last presenter, Karen Tingley. She is the Manager of Integrated Quality Management for the Catch and Pass Patient Experience Advisor Rounding at the Red Deer Regional Hospital Center. Karen?
Hello, thank you, Marie. I'd like to begin by thanking HQCA for recognizing our work in engaging volunteers in patient rounding and bringing our patients and families' voice back to the front line in real time. I also want to acknowledge that I'm here representing Red Deer Regional Hospital Patient Experience Program on behalf, and also the volunteer department within Red Deer Regional, as well as my team, Integrated Quality Management Central Zone. I'd like to give you a bit of background about how this volunteer program came into existence. The idea to involve volunteers in quality and patient safety improvement came out of a co-design day called Imagination Unlimited. The event was hosted by Calgary Central and South Zones, and connections were made there that would not normally have been made or ever would have happened. So after that day, volunteer resources, integrated quality management, and hospital leadership got together to bring those loosely formed ideas into reality. When we came back together, some of the enablers for the development of the idea were that volunteer resources recognized that volunteers want to have experiences face-to-face with patients, and they know that they're having a true impact and making a difference. Our integrated quality management team recognized that volunteers receive an extensive onboarding and sign the same confidentiality agreement as clinical care teams do. And so we were interested in engaging them with quality and patient safety. Concurrently, the Red Deer Regional leadership was considering how they could bring volunteers into collaborative care teams to enhance their patients' experiences. So as they say, the stars were all aligned, and we decided to trial the Patient Experience Advisor Program on one unit for 1 month. So the unit leadership introduced the Patient Experience Advisors as an integral part of the care team, and that they were initially asked to round on patients twice a week for a 4-hour period each time. When the patient experience advisor came to the unit at the beginning of the shift, they checked in with the liaison or the unit manager who identified patients who were appropriate for a visit. The patient experience advisors are provided with a few questions just in case they need to ignite conversation and get feedback on the unit processes. This helps inform the unit what is working well and not so well, with the intention of enacting changes that are needed to enhance patient care. Questions include: what matters most to you today? What went well or not so well with your admission? What do you think you and your family have been, do you think that you and your family have been adequately involved in your care? And do you have questions about your discharge? Most often, patients connected quickly with patient experience advisors because they recognize that they have time to listen, and that often these advisors have a hospital experience of their own that helps them to feel open and empathetic to each patient's needs and concerns. During patient rounding, volunteers capture questions, concerns, issues, and even recognition of helpful and cheerful staff that they can pass on as well. These catches, as we call them, are brought back or passed to the front line in real time to improve or enhance each situation. Questions, concerns, and issues are addressed as quickly as possible. Patient commendations or comments of recognition are posted on the unit's quality board and shared in various venues. During rounding, Patients often disclose what matters most to them today. It might be something as simple as John stated he was used to reading the paper every day, and so the volunteer was able to have it delivered to his room daily. Terry, who was a long-stay patient, recognized that she needed a haircut, and staff were able to facilitate a haircut for her. As we are aware, these acts of kindness can make a person's day and go a long way to help them to feel that they are truly working with a team that wants to enhance their experience wherever they can. Often, patient experience advisors hear of important information that should be shared with their family, with the entire interdisciplinary care team, and so they write that on the patient's bedside whiteboard. The patient experience advisors bring important information back to the care team through Cardex rounds or rapid rounds. Here are a few examples of some of the things that they bring back as information about their patients that the team may not have known before. Dennis was fearful of falling at home since his son, whom he lived with, works away for 10 days at a time. Knowing this piece of information, the team was able to pass that on to the discharge planner and on to home care. John was concerned about his diet because he was receiving conflicting information from the cardiologist and nephrologist. So the dietitian was asked to visit with John, and a dietary plan was created, alleviating John's concern. John was also worried about home care after discharge, so the unit staff was able to have a discharge planner connect with him about his at-home care needs. Linda has diabetes and had just been admitted into the unit the night before. While the patient experience advisor was rounding on Linda, her mother joined the conversation and shared with her that she had brought in Linda's insulin from home for self-medication. With this information, the patient experience advisor was able to alert Linda's nurse to the situation, which allowed the nurse to immediately connect with Linda and her mother to come up with a medication management plan to avert unattended patient harm. With continuous iterative changes, our 1-month trial period on the medicine unit was extended to 3 months, and now the patient experience advisor role is well ingrained in the unit's practices and culture. We found that each rounding shift typically results in 2 or 3 catches of new information, and the team had not known previously, and most often 1 or 2 staff recognitions. To assess the value of this new role, patients are asked 2 questions on the discharge survey. The team has been documenting patient survey results, the daily catches, as well as staff and volunteer perceptions of the program have been assessed during the 3-month trial period. To date, 83% of patients perceive that their patient experience advisor visit added value to their experience in the hospital. Anecdotal comments also confirm the same thing. Staff and patient experience advisor feedback have been extremely positive as well. And other good news is that there is high interest from the volunteer pool. And in fact, we have more volunteers trained and waiting to be onboarded, albeit not for too long. To date, this volunteer program is spread in 1 surgical unit, and 1 more medicine unit is waiting to onboard a volunteer within the week. Word of this program has gone viral within the experience and patient engagement community, and 4 other zones within Alberta Health Services want to learn how they can integrate patient experience advisors into their programs and sites. So our team would be happy to answer any questions that you may have or provide additional information. I just want to thank you for your time and interest today to hear about the Patient Experience Advisor Program at Ridgeway Regional Hospital and how it's making a difference in how we engage with patients and their families as members of their collaborative care team. I'll turn it back to you, Marie. Thank you.
Karen. It's easy to understand how patients would be much more comfortable speaking to someone who's not in a uniform or has a stethoscope around their neck who rushes in and out. And I really like the questions that you asked. Those would not be questions asked in the general provision of care, would it? So, but yet it gets such good information, doesn't it? So, well done. Okay, so it's now time for questions and answers. And we have time for a number of questions, actually. Cassandra, do you have some questions to read to us?
I do have one question, and it's for Heather. How do you ensure our engagement with patients is meaningful for them?
I think it's a bit of a balancing act, really. When we come into a situation where we would love to have the patient voice represented, it's really about being honest as to your own limitations as an organization and as someone doing this planning work, and being open and honest about how you intend on using the information and the voices that you are hearing, and what that individual who's engaging with you can expect as part of their experience. I mean, ideally, we would love to have a situation where we can show very tangible, you said this and this is what we did. It's not always the case, but I think as long as you're communicating that back in a respectful manner and being respectful of the person's participation and the time and effort it took to engage with you, I think the process itself can be a meaningful engagement, to have your voice heard and to be treated in a way, especially when you're in maybe a situation where you feel a little powerless, or where you don't feel like the expert. Having that opportunity and being aware of what that's going to be used for and what your contribution is for, I think that process can be meaningful for patients.
Thank you. We have another question, and it's a general question, so maybe we'll just start with Cheryl and work our way down to Karen. This question is, what was your biggest challenge in getting patients and families involved in the planning of your initiative?
I don't think we really had in our program a challenge with getting patients and families involved, because it was a high priority from the onset of the program to make sure that we had a patient and family advisor on our steering committee. And so even when the work started in the planning phase, that voice of the patient and family was always at the forefront, involved in what does this look like, what are some of the gaps that you see as a patient and family, and what things are going to be most important. And so again, in our program for sure, the voice of the family came out right from the onset when they kind of told us about their previous experience with experiences with EMS, and how sometimes that ramped up response isn't kind of what's preferred when patients are now more at end of life or wanting to stay at home. And we've had really significant patient and family engagement throughout as we've been doing our family surveys. So I don't think we've actually had much of a challenge there. People really want to tell us about their experiences and want to be engaged in trying to make things better.
I would actually say our biggest challenge was people were too nice. It was really hard to get at what maybe wasn't working well or what we could do to improve, especially in a situation where they weren't quite either sure or confident in their own ability to make some of these higher level process decisions. And what we really had to do was set up an environment where you built that relationship and that rapport, and you allowed people to engage as much or as little as they wanted to. Some people, the most feedback you were going to get out of them was, that was lovely, thank you so much. And others, if you asked some key questions and proved to them that you were actually listening and this is what you intended on doing, you started to piece together not only their experiences, but build their confidence to maybe start making some suggestions. And I think that was quite, when you have something that's very open-ended and you're planning very early stage, that overwhelming brainstorming or, that early development can be quite a wall. And you need to break it down into smaller pieces and give specific ways of, this is something you could help with, this is something, what are you interested in, let's match up some options there. So I now don't have a problem with that, but I'd say there was a period of relationship and trust building that was required early on in order to facilitate that deeper level engagement with a process building.
I think maybe for us the biggest challenge at first was figuring out how to start, because our project was started by a small frontline team of a couple doctors and a couple nurses. And I was relatively new to Calgary at the time, and so figuring out how to best connect with patients and families was something that I needed to learn. And luckily, it turned out that there were quite a bit of resources that were available to me. And so as soon as I started asking, I began to learn about that. And so, you know, we have a very strong patient family-centered care committee at the Children's Hospital, and their patient experience consultants. And so once I began reaching out, I learned how to do that, and I was given the support that I needed to make those connections. And so that's what we're trying to offer to the new sites that are participating with us, because for them that process might be new as well. And so for them to learn how to take those first steps to reach out, and knowing what resources are there to support frontline teams that are reaching out to patients and families can be really helpful. And I would say we also experienced a little bit of people being too nice. I think that sometimes families don't necessarily realize that needle pain doesn't have to be part of an emergency department visit. And so satisfaction isn't a great way at looking at the pain experience. That's why we focused on eliminating dissatisfaction. But really, I think we would like the public to be more aware of how a healthcare visit can be more comfortable for children, because we were quite often told that families were satisfied when in fact we probably could have been doing better. And so you know, really partnering with patients and families and having families informed of what comfortable care in an emergency department setting should look like is one of our ongoing challenges.
And for us, our patient experience advisors are patients and families themselves, and so we had them engaged from the very beginning. We didn't have the problem of them being too nice. we didn't have complaints from patients that they were too nice. But you know, it was wonderful having them to provide us feedback in real time, you know, as to how we might improve the program during each one of our PDSAs. Yeah.
Well, thank you. So we have 2 more questions, and then we have a few more minutes. So if anyone on watching the webcast wants to type in an additional question, we will have time for that. Our next question is for Jennifer. It is, if kids are now getting pain meds really quickly, does it make it harder to assess pain levels during physician assessments?
That's a wonderful question. I'm glad that someone asked it. It actually doesn't make it more difficult. In fact, it makes it easier. When children come into the emergency department experiencing a lot of pain, that's what their focus is on, and it makes it harder for them to communicate with us exactly what is hurting and where it's hurting. And so when children's pain is alleviated and they are more relaxed and their families are more relaxed, it's much easier for us to communicate with them. And when they're given pain medicine, it doesn't completely mask, for example, areas where they might be tender. So in the past, children would come to emergency departments with abdominal pain, and people would say, well, don't give them any pain medicine because we won't be able to find out if they have appendicitis. And it's absolutely not true. There's even really good research that shows that that is absolutely not a reason not to give pain medicine, and we can still make just as good of a diagnosis or maybe even better, and we can communicate with families better when pain is treated. So I'm so glad that that question was asked, and we want to get the message out to families that if their child is in pain or is hurt, they can go ahead and give them a pain medicine before they come to the emergency department, and they can expect us to address their pain as soon as they arrive.
Thank you. The next question is about catch and pass. It's, I see this volunteer position as being super important, but it would take a really good communicator and listener to be good at it. Has there been difficulty in finding appropriate volunteers for this important role? What is the training like? If it were expanded, are there enough qualified volunteers out there?
Mm-hmm. Yeah. I think one of the initial challenges was really finding a right fit between the program and the volunteer. And because of the great feedback that we had and the continuous opportunities to meet, come together and talk about what's working and what's not working, we quickly came to understand, you know, the profile of the type of volunteer that would help make the program successful. And so that's always sort of one of our, things that you need to know before you embark on the program. So that's a really good question. Thanks.
And we don't have any more questions, so I'll pass it back to you, Marie.
I have actually a question. Can you talk a little bit more about the screening process, Karen, that you would go through I mean, you said you had many people that wanted to volunteer to be a patient experience advisor. How did you sort of sift out the people that were really going to do the job that you wanted?
I think we are pulling right now from our current pool of volunteers, and so they have already had experiences within the volunteer program. So the coordinators actually know those who are really going to be successful and have the skills that are needed to, effectively communicate with patients and family.
Yeah.
In addition, they have some online training that they do about relating and responding well with patients. And so between that and just their passion to communicate with patients.
Great, good.
Worked well for us so far.
Good, thanks. Jennifer, I was just curious, and this just came to me. I worked for a number of years in small rural facilities, and we had got kids in regularly who were in pain.
Yep.
You've got some really good tools to deal with kids, whether it's assessing the pain. Would those be available to all? You're spreading to 54 now. That means there's still quite a few emergencies.
We've invited all of the emergency departments in Alberta to participate, and so any site can contact us, even if they weren't part of this initial wave of the project, because there were a few sites that weren't quite ready yet, but were still interested. So absolutely they can, as well as it doesn't have to be emergency department. We're happy to share our work with any other site that takes care of children. And in fact, I've even heard from some people that work with seniors that the concept of comfort is probably not just relevant to the pediatric population. So if there's anyone that would like to contact us, and we do have a project website now to facilitate communication. It's commitmenttocomfort.com.
Right.
And so that would be one way that someone could reach out to us.
Good.
And we'd be happy to share.
Yeah, they're great tools and customized so well for kids. Great. No more questions? Okay. Well, this brings us to the end of our webcast. Before we do finish, though, I really want to acknowledge the support and the participation in the planning of the awards program and with the shortlisting and judging process. This is a lot of work, as you can well imagine. And in particular, there were 3 representatives from HQCA's Patient Family Safety Advisory Panel, and they were really core members of the planning team that designed and developed this awards program. So a special thank you goes out to Geraldine Leroux, Byron King, and Darcy Duquette for your dedication to developing this awards program. And of course, I want to thank you, Greg, our representative from the Patient Family Safety Advisory Panel here today. And you as well were one of the final judges, so thanks so much for your involvement with this project. And lastly, I want to thank and congratulate our 4 presenters. It was good that you took the time out of your busy schedule. I know you're all busy, and so to come and present today was really was great to have you here. And I think that we all learned a lot about how we can better improve the experience of patients who come into our organizations and our facilities for care. I also want to once again thank all of you for your interest in this program, the Patient Experience Awards program, and I look forward to many more submissions about improving patient and family experience next year. So the 2018 awards program will be announced in the new year, so stay tuned for that information. This live stream will be posted on the HQCA's YouTube channel, and an overview about each program discussed with more details certainly will be found on HQCA's website, which is www.hqca.ca. So again, I want to thank you for being here, and I want to wish you a lovely afternoon. Thanks so much.